Hello, and thank you for joining us for the next 50 minutes as Megan Fragale and Valorie Wilkins share their valuable insights on successfully and safely implementing a smart syringe pump. Allow me to introduce myself. I am Carla Rodchat, a registered nurse with Baxter's medical liaison team. As a medical science liaison, I provide fair, balanced, non-promotional, research-based education and clinical therapy discussions. I'll be the moderator for this webinar. For additional information regarding this webinar or additional educational sessions from Baxter, do not hesitate to email me at carla_rodchat@baxter.com. Now let me introduce our fabulous presenters for Going with the Flow, a community health systems journey adopting a novel syringe pump. Val is originally from Seattle and went to pharmacy school at the University of Washington. She completed an ASHP, American Society of Health Systems Pharmacists, accredited residency master's program at the University of North Carolina. She holds a Master's of Business Administration from the Simon School at the University of Rochester and returned to the UW for a Master's in Health Information. She has worked in settings that include tertiary care urban hospitals, home infusion, and community hospitals. She has held a variety of leadership and clinical roles and is currently a clinical pharmacist at Cascade Valley, which is part of Skagit Regional Health. Here she serves as the campus automated dispensing cabinet administrator. She is also the system drug library administrator for multiple smart pump platforms. Val has worked with novel drug delivery systems throughout her career and is passionate about teaching how pharmacy clinical practice can be enhanced through operations and technology, which is why she enjoys her partnership with Megan to improve drug delivery and patient safety. Megan began her healthcare career as a registered dietitian specializing in the care of individuals with developmental disabilities. In this setting, her interests shifted to safe medication use. Megan has her Bachelor's of Science in Nutrition Sciences from the University of Arizona, her Master's of Science in Public Health Nutrition from the University of Tennessee, Knoxville, and a PharmD from the University of Tennessee Health Science Center. Having over a decade of clinical pharmacy practice in both small rural and large urban hospitals, she has gained experience in a variety of practice settings, including infectious disease, oncology, pediatrics, sterile compounding, and pharmacy operations. Megan is the Medication Safety Officer for Skagit Regional Health, which is a community health system consisting of 2 hospitals, 2 oncology centers, and over 30 ambulatory clinics serving 3 counties in northwestern Washington state. Megan oversees medication safety, sterile compounding, diversion management, in addition, on top of all that, to maintaining the infusion pump fleet with her colleague and co-presenter, Val. I'm sure that during this presentation, you'll hear that Megan and Val are very passionate about medication delivery and patient safety. Val, I hand it over to you.
Thank you, Carla. We would like to acknowledge Baxter's support in being with you today to do this presentation, but also emphasize that our opinions are our own and do not represent Baxter or our employer. And our objectives for today are detailed, formal, a little bit lofty, but instead of teaching to those, what Megan and I would like to do today is to really walk you through our journey in terms of what we learned and how the project went for us. We'll start with a little bit about who we are, how we assessed what we needed, where we were before the project started, how the build progressed, and how it changed along the way, and then some of the lessons that we learned moving forward. As with any new project that involves technology, we expected that our process would be complicated with lots of moving parts that would line up into neat rows. What we found along the way is that it was actually a little bit more complicated than that, and we will go into detail about how that worked. This is a model that Megan actually developed that we use to visualize our pump platforms and medication safety and all of the different moving parts we have in working with these systems, with an emphasis again on medication safety. As Carla told you a little bit during our presentation, um, we come from Skagit Regional Health in Western Washington. And what's unique to us is that while we're both public health district hospitals, our flagship in Mount Vernon is the larger facility with 137 beds, specialty services, and a 24/7 pharmacy. I work about 30 minutes south at our hospital in Snohomish County, which is only 48 beds and does not have a 24/7 pharmacy. And that's important because it impacted how we built our medication library for the pumps and the project itself. And because I suspect that many of you may also be in a situation where you have differences between campuses like this. Well, when we started out, our system integrated in 2016. And at that time, we had existing infusion pumps at each campus, but they were different. One of them had not had a new drug library uploaded for multiple years and was quite outdated. And while both campuses had some syringe pump systems, they were very limited and quite old. After the system integrated, we implemented a new large volume smart pump platform where we built a drug library to meet the needs of both campuses. And that was our initial experience with working, with the drug library and the new EMR and all of the things that came into play there. As that drug library was up and live for a longer period of time, we started to notice that we had some unmet needs that were not covered well by the large volume pump, particularly for some of our smallest or pediatric patients. And where this started was really around insulin. And we discovered that while we look to Children's Hospital in our area for our specialty care, because for us, pediatrics is very much a treat and transfer situation so that we can get kids to the level of care they need, we started to look at how we needed to transition children through that process and how that impacted our drug library and our infusion pumps. So we did some initial modeling with vasopressors, and we tried to match the drug library at Children's initially, but they use a different pump platform than we do, and the pump's capabilities are quite different than the one we used. So some of the concentrations that we were looking at did not seem to meet our needs, and we started to model what we might need to do and how we might need to change those, which is where our pediatric insulin build came into play and where I started working with Megan around pump technology with a focus on medication safety. This is how we visualize how we're working with pump technology and our platforms. You need to bear in mind that some of your technology will be used in a specialized environment, particularly somewhere like MRI. You may have specialty infusion or therapy types that need to be delivered, like epidurals, but our single largest variable is the patient population that we're actually providing care to, and that's where we spend most of our time with platform management and drug modeling. Now, to really select a pump technology that's going to meet your needs, you need to understand a little bit about how that works. Large disclaimer here, I am a pharmacist, not a clinical engineer, so please bear that in mind. There are a number of different pumps available on the market. Some of them are specialized, they have different methodologies, but you need to learn how the technology that you plan to adopt works. The biggest piece of that is to understand its flow rate and the variability of that flow rate and how it's affected over time. Learn the strengths and weaknesses of the technology that you're actually adopting. Look at variance at startup time, later, look at your trumpet curves, and make sure you understand the graph and the variables. And then bear in mind something that's not on this slide, which is some of the mechanical things that can affect your infusion, like your tubing or your pump position that may be in the background. So we went through this analysis. We put out an RFP to look for a new syringe pump because we were interested in a delivery device that handled infusion flow more accurately at smaller pediatric volumes. We selected a pump, we put the project together, we did some initial planning, and we started to learn a little bit about what we didn't know. And at this point in the process, we still thought we were working with something that was just a little bit complicated. Initially, planning went exactly as you would predict. We had a project manager, a sponsor, all of the players in the left column that you would expect to be part of this project. What we discovered along the way as we started to work with the process was that we needed some additional support, both in terms of knowledge and build assistance from some other folks within the system. And by that, I mean our EMR informatics team. We needed to work more with materials management as we learned that a syringe is not a syringe. And there was a larger volume of drugs impacted by this change than we had initially impacted and or expected. And some of this had to do with the fact that we had to do a significant amount of after hours build because of the fact that one of our campuses was not 24/7. And of course, our focus through all of this was how do we build it so that we know it will be safe and is built correctly. So that meant that we also had some changes in our project deliverables as we went along. We always knew that we would be producing a drug library with care areas, and we had some therapies we expected to assign to it. There would be some training and education involved around the pumps, and then we would, gracefully transition to having the pumps up and running and following some CQI data. What we discovered was that there were actually some other deliverables that we weren't expecting. There were operational changes that needed to be put in place. Where are you keeping the syringes that you need to provide therapies? How does a pharmacist know what syringe size to use? How would we need to change the drug library for our large volume pumps if we were transitioning therapies to the new device? And there were also changes in policy. And we had the ability to deliver some new therapies that we had not been able to with our small volume pump. Looking at all of those things, we did a lot of planning and collaboration. We spent a lot of time talking to folks that we both expected to be part of the project initially and that we added to it as we went along. We ended up learning a large number of new tools. We had multiple new software packages and servers. We had to learn how to get the pumps onto the network and work with the team there. And then our build process, which we'll tell you a little bit more about later, also had some new tools in it and some new spreadsheets. And then the education that we were going to need to provide to folks who both worked with the pumps directly at the patient care level and then in the background was a little bit more than we were expecting as well. So we did a lot of things here that were not as build specific as you would think. We spent a lot more time doing these activities than we had anticipated. And this is where I'm going to turn it over to Megan because a lot of those things directly impact patient safety, and that's where her focus starts.
Thank you, Val. Val and I like to joke that this is my brain on paper or on the slide in front of you. But truly, as a medication safety officer, one of the models that I utilize to build safety into drug delivery is the medication use process. This model comes from the ASHP guidelines on preventing medication errors in hospitals, but you also might recognize it as a model that has been modified from the Joint Commission's medication management system. So medication errors can occur at any point along the medication use process. Therefore, when developing strategies to prevent medication errors, the boxes on this diagram represent the key areas that I consider to prevent errors and mitigate risk for patient harm. The medication use process typically flows as represented by the arrows connecting the boxes. Traditionally, smart pumps would fall under administration, and I would be thinking about things like nomenclature, where the EMR order matches the dispense label, which should also match the drug library entry. But as we work to implement the syringe pumps, I wanted to use this model to assure that we were addressing all of those safety risk points, but it did not quite fit the work that we were doing. That work ended up looking a little bit more like this. I call this a model for safe smart pump use. Also, I specifically say beyond the drug library. The reason for this is that the pharmacist's traditional responsibility is programming and maintaining the drug library. Through this journey, we learned that in order to ensure safe drug delivery, we would have to address the key elements you see here within each gear of this model. And the metaphor that we are trying to illustrate by using interlocking gears is that all of these elements are necessary and work together so that drug delivery via any smart pump is safe. Prior to syringe pump implementation, I had two safety goals. First, I wanted to align our system's standard drug concentrations with ASHP's Standardized for Safety initiative. This national initiative aims to reduce medication errors by standardizing medication concentrations, which is of particular importance during transitions of care. Any patient is at a higher risk for medication errors when there is a need to transition care. That risk increases by using non-standard concentrations. Neither of our two hospitals supports long-term neonatal or pediatric critical care. Due to the limitations of our existing large volume smart pumps, we had to utilize non-standard concentrations to accurately administer certain drugs to small children. The syringe pump expanded our pump delivery options by giving us the opportunity to adopt standardized concentrations that could safely be run at rates lower than our large volume pumps would allow. My secondary goal was to standardize drug delivery across our two hospitals. The smaller hospital closes overnight when remote pharmacy coverage is provided by the larger hospital. Drug dispensing at times has been inconsistent and complicated, and I wanted to take this opportunity to streamline ordering, dispensing, and administration. We will go through each element or gear throughout the remainder of the webinar, starting with drug modeling. Drug modeling is the term we use to determine the possible infusion rates that a drug can be administered based on patient weight, the drug concentration, and a range of dosing rates. We create spreadsheets to model each drug in order to calculate the minimum, typical starting, and maximum rates that a given drug may be administered. Drug modeling is our most valuable tool because it gives us the necessary information to decide the appropriate cutoffs for when it is appropriate to use the syringe pump versus the large volume pump. So let's revisit our pediatric insulin example. Here we have pediatric insulin modeled on a large volume pump. The top section is our standard insulin drip concentration of 1 unit per milliliter, commonly used in adults. The bottom section is our non-standard insulin concentration of 0.2 units per milliliter. Prior to adopting the syringe pumps, we felt it was safer to use the 0.2 unit per milliliter concentration for our smaller patients for two reasons. First, the lowest rate our large volume pumps can run is 0.5 milliliters per hour, making it impossible to administer insulin at the 1 unit per milliliter concentration to our smallest patients when a rate lower than 0.5 milliliters per hour was ordered. And secondly, and even more important, large volume pumps normally have a 20% variability, plus or minus, in infusion rate doses below 2 milliliters per hour. Therefore, using a more dilute 0.2 unit per mil concentration was necessary to assure accurate drug delivery for our smallest pediatric patients. Using a non-standard concentration meant that we had to build safety into all processes surrounding insulin drip delivery. We were acutely aware of the particular risk with transitions of care, as neither of our hospitals would keep a pediatric patient that was on an insulin drip. So the risk of a 5-fold overdose if concentration was not addressed in a transition of care was very unsettling. This is pediatric insulin modeled at the 1 unit per mil concentration for syringe pump delivery. Our syringe pumps allow for infusion rates as low as 0.01 milliliters per hour. Again, our large volume pumps run at a minimum rate of 0.5 milliliters per hour. So adopting the syringe pump gave us the opportunity to use the standard 1 unit per mil concentration for all of our patient populations, minimizing the risk of an error between transitions of care for the pediatric patients that would be transferring to a higher level of care. But there is more to consider. Just because you can doesn't mean you should. These simple yet wise words from Val are intended to prompt critical thinking about the technology that we are working with. Understanding that technology is critical to ensuring safe drug delivery. The pediatric insulin example shows how syringe pumps are preferred for medication delivery when a low flow rate is needed, because syringe pumps allow for the most accurate and uniform flow at low rates. An inconsistent rate of delivery can result in serious clinical consequences, as noted in the FDA safety communication shown here. Such consequences include delay of therapy and over or under infusion. Clinicians must recognize the potential safety issues associated with normal syringe pump operation, such as startup delay, potential for post-occlusion boluses, and the impact of tubing diameter. These risks can be mitigated through strategic design and standardization of all processes surrounding syringe pump operation. Also imperative is assuring end user competency so that risks are recognized and managed at the bedside. I will talk in detail about syringe selection next, but I want to highlight the importance of bedside knowledge and practice. New this year to the Infusion Nurses Society Standards of Practice are recommendations addressing safe drug delivery by syringe pump. These standards of practice highlight the need for standardized concentrations and the use of optimally sized syringes and administration tubing. They speak to establishing protocols for syringe and administration set exchange for high-risk continuous infusions, as well as ensuring proper pump height relative to the patient to minimize or eliminate variation in drug flow rate and inadvertent bolus delivery. Bedside practice can have a far more significant impact on drug delivery at low infusion rates. As mentioned on the last slide, syringe selection is a key factor contributing to safe drug delivery via a syringe pump. So, not all brands of syringes are manufactured alike. Using syringes identified as compatible by the pump manufacturer is key to reducing the risk of inaccurate drug delivery. Additionally, syringe size matters. Knowing the minimum recommended flow rate for each syringe size is essential. Generally, the smallest size compatible syringe should be used. This is of particular importance with high-risk, life-sustaining medications running at low infusion rates. Think less than 1 milliliter per hour. This chart is an example of two different brand syringes, A and B. If you compare brand A's 3 ml syringe with brand B's 3 ml syringe, you see similar minimum possible flow rates, but different minimum recommended flow rates. This becomes a critical consideration when selecting syringes for continuous infusions running at very low rates. For our purposes, we simplified this information into a smaller chart for use when drug modeling. This simplified syringe size decision chart shows the minimum infusion rate range in the left-hand side column. In the right-hand side column, we indicate which brand and syringe size could or should be used. While this is very simplified, it gives the pharmacist guidance on a reasonable syringe size to dispense when starting a titratable infusion on a patient. We copy our simplified syringe chart into every drug model spreadsheet for our reference. We then look with a critical eye at the possible rate ranges. To the right, you see that we've listed the possible syringe sizes that could safely deliver the corresponding weight-based ranges. We also wanted to assure that we dispensed at least a 4-hour supply of drug. We selected the 4-hour minimum supply time to cover drip initiation and transfer travel time for our critical pediatric patients. This is certainly not an exact science, but rather a balance between our facility goal of stabilize and ship with safe smart pump drug delivery. Another key element of drug modeling is keeping good notes about decision-making for when you program the smart pump. This drug model spreadsheet is different from the one that I originally showed because it has notations on it that are meaningful to us. For example, the weight ranges are grayed out for patients so young that we would not expect to see them present with a need for an insulin infusion at our facilities. The rates in red are high enough to safely deliver via our large volume pump. Taken together, we make some general notations about the particular drug and assign the infusion rate units and soft, hard, upper, and lower limits as applicable. After modeling several drugs, it is easy to forget why you made a particular decision, so we recommend documenting your rationale. As I have shown with the pediatric insulin infusion example, depending on the patient's weight and the rate of infusion, our smart pump platform may change. So I will hand it off to Val to guide you through pump platform selection and management.
Thank you, Megan. We've tried to present how we select and assign medications to a particular infusion device to the one that they are best suited for. But in addition to those ideas being a conceptual exercise with spreadsheets, they can also be challenging to operationalize. And as we worked our way through the project and discovered new inputs or outputs or deliverables, um, we got all of the project done. We knew what we had. Something that's continued to evolve, though, was how important it can be to continue to manage some of those decisions and those systems proactively. And that's really what we have now termed platform management going forward. The first step in any kind of a platform management with medication infusion devices is to keep track of your data, as Megan just alluded to when she said we need to document your decisions. So we built a folder structure on one of our shared drive for the pharmacy department, where each infusion device that the system uses has its own folder. There is a folder specifically for platform management, one for literature and best practice. We've got a form for folks who want to request that a drug be added to the library. And then the last item on here, the drug library updates and changes, is actually the spreadsheet that we are now using to document and communicate with pharmacy staff what changes were made in the drug library, when it was uploaded, and what it's intended to accomplish as a part of ongoing communication and education. So for us, drug modeling drives the platform selection, and I wanted to talk a little bit about how we would pick a particular platform to both deliver a therapy and how we might transition from one to another. Some of our initial questions and modeling were clearly driven around clinical rationale. What is the drug? What is the patient population? And then, as Megan has described, we model that very specifically for each drug or dose or indication. And sometimes we will do that for multiple concentrations or even multiple indications. And then we will select the device we want to put that on and verify that we have the correct weight or age breakpoints. But one of the important things in platform management is also transitioning from one platform to another. And I'll come back to that in just a minute. This particular graphic is a very simplistic version about how we start to make decisions in which pump platform we want to use. We will differentiate between continuous and intermittent infusions. We will look to see if the volumes are large or small, what the flow rates are. And then, as Megan has discussed a little bit too, is that a standard concentration or is it a new concentration? And then right before it goes into the giant build box, there are a number of other things that go on as well. Point out that there's a great deal of checking and validation of that build before we operationalize it. So, what do we exactly mean by platform management, and what kinds of other factors go into that discussion? Some of the other decisions you might have to make when building a drug library are to do with basic things that you've defined for care areas. What are your upper and lower weight limits for that? Do you want your care area weights to overlap, or should they be inclusive or exclusive? How do you handle big kids and small adults, for example? What breakpoints are you going to use to move from one drug delivery platform to another? And the answer to that one is basically it depends on the drug. How do you name your medications? Is that consistent with your EMR? And then from a safety perspective, how do you manage all of this to drive clinicians to the correct pump? Can you use clinical advisories and the EMR to support that functionality? What staff education might you need to do initially, and what might you need to do later? And then remembering again to document all of your decisions moving forward. And I have some examples I'd like to walk you through to show you how that works, which takes us back to insulin and continuous infusion. And this is the spreadsheet that Megan showed you earlier, but what I would like to emphasize on this slide currently is where you see where it says weight less than 40 kilos, we're going to use the syringe pump. And at a weight point greater than 40 kilos, we're going to go up a size essentially, by moving to a large volume pump. And that really has to do with flow rate, since we not only have to worry about travel time, as Megan alluded to with some of our pediatric patients, but too frequently changing a syringe on an infusion device is also an error risk. This is a snip from an early spreadsheet that we used to keep track of what drug we had built for which platform. And I would like to point out that for every line item on this particular slide, there is at least one spreadsheet model behind it. And if you look at the top of the table, you can see where we had the insulin and we have it assigned on a syringe pump to multiple care areas. We're using the same concentration between care areas there because that's our primary goal. And then you can see where the insulin pediatric, the 0.2 unit per mil, is actually marked for deletion. So you need to remember to remove things from a drug library where you do not want them used and you're deleting the drug. Dobutamine here is an example of where we have multiple concentrations that are built for different infusion platforms. We use a lower concentration for smaller pediatric patients using the syringe, and we use a higher concentration for adults on the large volume device for adults in a normal care area and in anesthesia. But as you can see, I've actually got marked the pediatric 1 milligram per mil dobutamine for both delete and rename. We opted to keep that concentration for some of our larger kids because we like the flow rate modeling better on the lower end of that. And the reason it's marked delete and rename is that we kept the concentration on that infusion platform, but we renamed it so that it would be more readily identifiable both on the pump and in the EMR. The next example I have is that for some of the drugs you're looking to model, you may have a fixed concentration, either because that's how the drug is more stable or that's how it's available commercially. And acyclovir is an example of that. We tend to use a 10 kilo mark to bridge many of our drugs from a syringe pump to a large volume. And that worked for this particular drug, where we were using a syringe for volumes that were less than 50 mils. And again, we have a spreadsheet behind this for every drug we've modeled. We also use a 10 kilo or less mark for syringe to piggyback for many of our antibiotics that you would consider, the beta-lactams and the things that are not volume driven, but are in fact dose driven, where you can add a particular dose to a mini bag for larger patients, or you can use a set concentration to a particular volume limit for some of our smaller patients. And this is the modeling that we did to ensure that our generalized rule of 10 kilos and up for mini bag and under that weight for kids for syringe pumps would actually work practically, because we verified that every dose and every volume would work on the platform we were assigning it to. Where we would like to end up, obviously, is that we've got the right concentration on the right infusion device for everything that we've built, that our care areas and weights are selected to do what we need them to do between patient populations or service areas, that our naming convention is matched across the EMR and the pumps, and that the drugs or concentrations that we no longer need or don't consider safe are either deleted or modified to drive users to the correct platform. And this is particularly important, for our smaller facility that does not have pharmacy services 24/7. Now, Megan is going to talk some more about programming, operational integration, and safety.
So we'll start with programming. So as far as the EMR considerations, we expected to streamline nomenclature, rate units, concentrations for safety by matching the drug in the pump library with the EMR orderable. We anticipated that we would have to address the dispense label as far as assuring it was clear to the compounder and the end user. And we also expected to address syringe compatibility and syringe size within the EMR. But what we had not realized was just how much we would need to rely on our informatics pharmacist partner to program the EMR to drive pump platform selection. That weight-based threshold that Val discussed was key in the decision-making to allow for this functionality. Additionally, whenever possible, as a safety person, I wanted to take advantage of opportunities within our EMR to specify syringe selection directions to the pharmacist, preparation instructions to the compounder, which would of course appear on the dispense label. Clear equals safe. As far as programming the drug library itself, dedicated, uninterrupted build time is critical to safe programming. When we realized the time we needed to build the drug library safely, we elected to implement a phased drug library rollout. And we strategized on what drugs to roll out, as we needed to address some immediate gaps in drug delivery, but we also wanted to assure that the end users were competency trained and could maintain that competency training on the syringe pump use. During the build, we used a completely independent double check process to minimize mistakes. And while drug library vetting is a given with a new smart pump rollout, seeking true multidisciplinary input outside of vetting is critical to assure the library is built correctly. It is important to go into the syringe pump build recognizing that the drug library is dynamic. It is regularly changing and growing. There are always new drugs to build. And so we have a form that's shown here on the right that we provide staff so that a build request comes to us with as much information as possible. We then follow a checklist to assure that no step is missed. Another complex part of safe drug delivery via smart pump is operational integration. So what encompasses operational integration? Essentially, we test to determine if the programming of both the EMR and the smart pump works as intended. So is it orderable? Does the EMR select the correct dispensable for the correct smart pump platform? We test the EMR using a range of weights with particular focus on outliers, meaning our small adults and our big kids. We also test to determine if the EMR works correctly at each campus and if it works after hours, given the pharmacy hours of operation differences between our campuses. Is it dispensable? Admixture changes were necessary for certain drug builds. Therefore, we tested to assure those changes worked correctly. We verified that the added preparation instructions were unambiguous to compounders, which was most critical when non-pharmacy personnel compound after hours at our smaller site. And then finally, is it infusible? Is the pump actually programmed correctly? Is it clear that a compatible syringe was dispensed so that inaccurate drug delivery and other safety risks are minimized? We promoted compatible syringe use throughout our organization. Addressing compatible syringe selection within the pharmacy was accomplished by collaborating with our pharmacy operational leaders and buyers. We utilized the EMR to address compounding with compatible syringes. Much more challenging is assuring the areas outside of pharmacy, the patient care units and the operating rooms, that those areas are stocked with compatible syringes. We learned that good relations and clear communication with materials management is essential to establish understanding of the necessity of compatible syringe stock. Helpful functionality within the pump itself is that the compatible syringe brands and sizes are actually programmed into the pump. Therefore, the pump tells the end user if the loaded syringe is not compatible. As far as staff competency with syringe pump use, we feared that infrequent use of the syringe pump was a safety risk. So we took advantage of our EMR as well as built clinical advisories into our pump platforms to support our staff. We also provided staff with other tools, such as publishing our drug modeling and platform management spreadsheets on our network drives as references for them. And finally, education. Inside the pharmacy, we utilized daily safety huddles with written minutes to relay information about upcoming changes like the syringe pump go live. Key topics were repeated to assure all staff awareness. We also provided a pharmacist in service with detailed written reference that contains instructions on where to find their tools. A sample of this written reference is on the right side of the screen. I call it a WINK, which stands for what I need to know. Outside of the pharmacy, we rely on our clinical education team to continually educate staff, but we also enjoyed the support of the vendor education team before, during, and after with the first week of go live with the syringe pumps. Our educational focus was on understanding the technology, syringe compatibility, and syringe size selection. These key safety points could not be overemphasized. We trained all staff on their resources for troubleshooting. We wanted staff to understand that if something is not programmed into the pump, there is a reason. We encourage staff to ask questions to understand why they can or cannot use a particular pump to run a particular drug for a particular patient. This is not easy to just run across the board on all patients. So as the medication safety officer, I try to foster an environment of transparency. And Val and I make ourselves really accessible to staff, and we have built relationships throughout our organization, which ultimately has resulted in open communication and promoted a culture of safety. Accessibility, transparency, communication, all of these things have contributed to a successful and safe pump implementation. And it really is all about safety. Adopting the new syringe pump gave us the opportunity to strengthen safety throughout the medication use process at our organization. It's been a wild ride, but it's been wonderful. Val's going to share some other tools for success and learnings.
Thank you, Megan. Okay, there we go. Given all of the things that we've talked about and all of the steps that we've been through, I think Megan and I both agree that we have, as a result of this process, a better system. Some of that is due to tools that we now see as critical for success moving forward. And the first of that is just organization. You'll never remember everything you did if you don't know where you put it. So work on that one. A drug library and working with your pumps is an ongoing process. The days when maybe you uploaded a drug library once a quarter are long gone. We actually use our drug library upload process now to verify pump connectivity, which is an ongoing consideration for us. Make time to check on how you're doing. Look at your DERS software. Pay attention to what it's telling you. Look for gaps in your drug library where people might be bumping into things they should or shouldn't be? Are there gaps you can identify that way? And make sure you actually integrate the pumps and the whole build process into ongoing pharmacy operations. For example, I sit with our EMR team every week as they discuss new build and things that go on. And one of the questions for anything we do with our EMR is, does it affect a drug that's on a pump? Make sure that when you have things that go well or sometimes don't go so well, that you look to tie that back to medication safety. Is there anything we can do using technology, either on the pump or the EMR, to make the drug use process safer? And then just to emphasize again, platform management is not all about just software. It really is about where you put something to be infused and why. So we've talked about a really wide range of some very specific technical, operational, and safety topics. But what I think is important to realize that while this may at times be very daunting and seem overwhelming, I know I might have had a couple of moments like that myself, it's important to remember that as pharmacists, this is what we do. Our medication use systems have never been simple. We just need to continue working with those as they evolve, one piece at a time, and not be overwhelmed by what may at times sometimes seem like a very complex, complicated situation. So, what did we learn through all of this? You will miss something. You'll discover a gap in a library that you've uploaded. You'll make mistakes. You may adapt or change how your process works, either in terms of build or communication, or how you roll it out to make it safer as it applies to your institutions. The supply chain is going to continue to be unpredictable, and having medications to infuse using your infusion devices is key. You may need to pivot to different concentrations or infusion methods that are supply chain driven. And then lastly, remember that you don't know what you don't know, but that as long as you focus on monitoring and medication safety, you will catch up with that. So these are our key references for your perusal later. If you'd like to look at some of the background materials that we've referenced either in the presentation or that we use to develop it, I would encourage you to take a look at these. And then lastly, all of us would like to just take this opportunity to say thank you for hanging in there through this presentation, and we hope that we presented something that you will find useful.
Great. Thank you, Megan and Val. I also want to take this moment to express some very important thank yous. As Val said, to the clinicians that listen to this webinar, thank you for your time today to listen to Going with the Flow, a community health system's journey adopting a novel syringe pump. And to Megan and Val, the Baxter medical team would like to thank you for your time today and for all the time you put into developing this presentation and your willingness to share your insights. Your passion for medication delivery safety and patient safety is evident in this presentation, as it is in the many interactions I've had with you over the years. On the slide, you can see that Megan and Val have been kind enough to provide their email addresses if you would like to contact them with specific questions. You can also reach out to me for additional information on this webinar or other available webinars from Baxter's medical liaison team. Please take 5 minutes to complete a short survey. Your feedback is valuable, and it will help Baxter's medical team develop relevant future webinars. This concludes our call.